This
Are you
conference
there?
will now be recorded.
Okay, we're being recorded now. Janet will join us in a minute. I'm John. This is AnCan's January 23rd, 2024, high-risk advanced metastatic prostate cancer support and education group. I've got some acknowledgments somewhere here to some of the organizations that have made this possible by their donations, which are not connected to any strings or conditions. But here I go. Okay. Thank you to Bayer, Foundation Medicine, Janssen Oncology, Myriad Genetics, Myovant / Sumitomo Pharma, Telix, and Blue Earth Diagnostics.
And keep your fingers crossed, and maybe we'll be able to bring Pfizer back into the fold. I'm meeting with them on Thursday morning. We'll
Okay. We'll see what the Rick Davis charm accomplishes.
see. Actually, to be honest, what I truly need is a minder. Never mind charm. For meetings with certain companies, I need a minder. So if anybody wants to show up in San Francisco and escort me.
The minder gets to carry a taser and stick Rick with it if necessary. So we might get some volunteers there. For you newcomers and for you students, the newcomers in our group are very, very important to us. We all know what it's like to be a newcomer. Some newcomers are brand new to diagnosis and are still confused and terrified, and some newcomers have already been through maybe an extended period of time of active surveillance or low-level treatment, have had recurrences or metastases, and shift into our group. So I'm going to start by introducing the newcomers and including a fair amount of relevant history of their prostate cancer. When we get through the newcomers, which will probably take us to somewhere around 7 o'clock Eastern time, we'll start going down the list of people who have questions and updates and things like that for us to discuss. So, Don, I'm going to usually what we do, as you know, Don, is go through an interview process. But since I have so much information about you already, I think I'm going to just present your case, if that's okay for you. And then when I'm done, you can make any corrections or anything.
That's fine, Dr. John.
Okay. Where are you from, Don? You from Florida?
I live in Boca Raton, yeah.
Okay, another Boca Raton. I think Paul Frieda lives there, if I'm not mistaken, or near there. Oh no,
David Muslin does.
Oh, David, yeah, David Muslin. We have a couple of guys from your neighborhood. Don is 71 years old, and he got originally diagnosed with a Gleason 4+5 back in 2022. His PSA had peaked at about 5.6 a few months before that, and he elected a prostatectomy in the spring of 2022. His post-prostatectomy pathology showed positive margins, a lymph node, and a seminal vesicle with some invasion. So he was right off the bat de novo metastatic, although at least it was a local lymph node. He about a month or two after that, he was started on ADT, specifically Eligard, 3-month shots. and abiraterone with prednisone was started about a month later. His ABI is a little bit unusual dose at 750, and his prednisone is also a little bit unusual dose at 10. His team advised him to have 3 months of ADT. 3 years of ADT. Wishful thinking there. 3 years of ADT, with 2 of those years accompanied by ABI and prednisone. A couple of months after that, he achieved an undetectable PSA. But because of some very interesting and confusing imaging findings that I'll tell you about, he went on to have 34 IMRT treatments to the prostate bed and the pelvis for a total of 68 gray over the next few months. His radiation oncologist is Dr. Abramowitz, if anybody knows him, and his medical oncologist is Dr. Minocha. His questions, besides introducing himself to the group, he's been following us for a long time, so he kind of knows us all, but his questions are a nodule that I'll tell you about, whether we should consider it to be whether we should consider it to be malignant or not. I've already formed an opinion of my own, but we'll see what the rest of you think. And he's also wondering whether he really has to do 36 whole months of ADT. As he knows from watching us, we very often get assigned to 24 months. If I remember, there's some genetic information here somewhere, isn't there? Let's see.
I've had two genetic tests.
Okay.
One is from Invitae, and my copy I can't even read, so I'm going to have to get another copy. And another one I got was from the South Florida cancer specialist, and I think they're in-house. It's solid tumor NGS profile.
Okay, so that's a somatic test of the pathology that was taken out of you by the surgery, probably.
Right, and the Invitae, the one I had at the University of Miami, I think is the same thing, because I could see on my chart where a couple of the segments of the prostate core was sent out.
Did those genetic tests come up with any mutations,
None,
deletions, anything? Nothing.
nothing.
Okay, so let me tell you a little bit about this nodule that's concerning him, and then we'll turn it over to him to complete the story. He's had a number of MRIs, usually with PIRADS 5. He had an MRI before biopsy, MRI used for the fusion biopsy, and he had another one after his surgery. And there is a PIRADS 5 lesion in what is called the vesiculourethral anastomosis. So here's what that is. The vesicle is the bladder, and the urethra we're all familiar with. When the prostate is removed, the urethra is cut away from the prostate. The urethra goes right through the prostate, but it has to be cut, and the two ends have to be sewn together. Sewing together the two ends of the urethra is called the anastomosis, and right at that particular junction, he had a lesion that showed up on MRI, and then on another MRI sometime a few months later than that, or no, maybe a whole year later than that. Oh no, it was a few months later than that, I think. It was stable. It was not growing any, and but the contradictory evidence is that he had a PSMA PET scan, which in which the area did not have uptake, and he also had a cystoscopy in 2023 which also was not able to find it. The area was described on the PET scan as slightly lighting up, and on another PET scan was described as no uptake in the surgical bed. There's a lot of speculation in here about whether this might have to do with some scarring from radiation, because there was a lot of intensity in that particular area based on the earlier MRIs. The only other thing I can tell you here is that he has osteopenia and is now on Prolia. That's what I got. What did I miss, Don, and if anything?
You missed nothing. Thank you very much.
Anybody want to chime in on or ask questions about his two questions or his situation in general?
Just
Don,
repeat,
did you have
John,
urinary symptoms?
Yeah, I was monitored for BPH at the University of Miami for like 4 years before my PSA started going up.
You didn't have any procedures done for BPH. You didn't have any TURs or anything like that.
I did not. In fact, I was in the process of researching like a few, the Resume and the other one where they stick the thing through the side, and that's when the cancer was discovered.
Dr. John, could you just repeat the two questions that that Don
The
had,
first
please?
question was, is this lesion at the junction of the bladder and the urethra, where the urethra was sewn back together, a metastasis? And the second question was, is it necessary for him to have 36 months of ADT? Could he get away with 24?
Len, you want to have a shot at that second question?
Well, I believe that the NCCN guidelines are for someone like Don recommending 24 months. I don't know about 30. Was that what they told you, 30, Don?
Yeah, they told
36.
me that under Stampede, the results of Stampede, that 36 months is what I should do. I have spent hours and hours researching Stampede, and I can see nothing from the results of Stampede suggesting that 36 is superior than 24. They went into it thinking that the norm was going to be 36, but I can find no data out there, no science suggesting that 36 is the standard now.
I think that might have been a little bit older thinking.
Yeah.
More recently, they're talking about 24 months, probably sufficient, especially when you consider the long-term side effects of ADT on especially you're already osteopenic, muscle atrophy, potential brain fog, all these sorts of things. You don't want to do it longer than you have to. The other question at the anastomosis, I'm not sure I'd call it a metastatic, even if there is something there. It's more like a local recurrence, isn't it, John?
Technically, I suppose you could argue that it's slightly outside the prostate because it's in the urethra.
But even then, I think like I had pelvic lymph nodes lighting up on my diagnosis, and it was considered locally advanced, not metastatic. But I think metastatic typically implies outside of the pelvic region. But anyway, I guess it's not important how you describe it, but So you said the PSMA PET scan showed maybe something a little suspicious, but
The first PSMA PET was read as totally negative. Then I went down to a Dr. Alan Pollock, who's the head of the radiation oncology department at the University of Miami. He,
yeah.
what a great guy. He pulled up all the scans and he reread them in front of me. And when he reread the PSMA PET in that area, it glowed. He showed me the glow. And other doctors since then have seen that. That glow did not reappear during the second PSMA. And this is what the doctors tell me. My surgeon, Dr. Gonzalgo, who is really preeminent in this field, he thinks it's just some form of scar tissue. Dr. Abramowitz, who is my radiation oncologist, he says, okay, even if it were cancer, number one, there's nothing we can do about it other than the treatment you're already on. It's in a position that we can't re-radiate it. So you might as well just let it go.
Sounds good to me.
Any
I've got a
action on your PSA? Are you seeing any movement at all on your PSA, or is it still undetectable?
It's been undetectable. It's taken every 4 to 6 weeks since August 22.
Okay. So I'll make a comment, and then I know Peter has his hand up too. The 36 months comes from a trial, I'm guessing was probably sometime around 2010. At that time, back in 2007, the main trial that they had was one that showed 4 versus 28. And so 28 months was pretty much the standard. And then within about 2 or 3 years after that, and of course, remember, this was all monotherapy LHRH. And there was another trial that came out that compared 36 to, I can't remember what, 6. I think it was 36 versus 6, and the 36 was better. So now we had, well, is 28 better than 36? And I remember going to my radiation oncologist, Mac Roach, and saying, well, instead of doing 28, should I do 36? And he basically threw his hands up and said, who knows? He says it just depends what they pick. And that was where the 36 came from. Then another trial came out that was 18 versus 36, and it didn't seem to show much difference between 18 and 36. So this was like the third one. So then we were looking at 18. Over the years, I think what we've basically arrived at is that, and this is what's reflected in a lot of the guidelines, the AUA and the NCCN, as Len said, I'd have to check it, I can't remember off the top, but I think that 24 is pretty much a good number. But again, that's 24, and that's also based on probably today doing an additional second line antiandrogen, which is generally recommended. We've got somebody's sending us notes about someone is waiting unlocked to let people join in. We're not locked. I don't know what that's all about.
I've never seen that, and I don't know what to
I've
do
never
about
seen
it.
it before either. I don't know what that's all about. Anyway, Peter, yeah. Anybody can come in. It shouldn't be. There's no limit on the room, and they should be able to come in. Peter, you had a.
Now, Don,
something.
are you already on ADT?
Yes, I've been
Yes.
on ADT for 18 months.
Okay, so that's why you're asking. So you got another 6 months, and and then you can make a decision. A number of us have done intermittent over the years, on and off, on and off, on and off. Are you doing Orgovix or are you doing a Lupron shot?
Eligard, Lupron, yes.
Lupron. Okay. Um, yeah, good question. Um, I agree with Rick. I don't think there's a definitive answer. I mean, there are guidelines and so forth, but nobody really knows. And this is an expanding and ever-changing field and debate. Things are changing so fast. New treatments are coming out. Orgovix came out a few years ago. I mean, who knows? In 6 months from now, it could be a very different field to look at. How are you tolerating the ADT? Are you doing okay with it, or is it debilitating?
No, I'm not debilitated at all. I mean, I'm living a normal life, but I'm 71 years old, and I do have a little brain fog. I do have some fatigue. I force myself to exercise. I'm on the bike a lot. I'm in the gym 3-4 times a week. I swim 3-4 times a week. I walk. So yeah, I'm fighting it really hard. But I'm looking at it in terms of I'm 71. I'll be 72 at the time I stop. I mean, if it was 36 months, what is what's the benefit in terms of overall survival or metastatic free survival? And I can find no data on that.
I don't think any of us can. We're all individuals. Some of us we're on it for years. Some of us, as I said, we're intermittent. I mean, you've got 6 months probably now to think about this. I don't think you're going to come up with a definitive answer, but in 6 months from now, you might know whether, the hell with this, I'm going to take a break, which is a perfectly legitimate. If it was me and it's been me, that's the way I've written it. And my docs are starting to throw that out at me again. Oh, you want to go back on it? And I'm digging in my heels now, right now, because nobody knows for sure on this stuff.
Yeah, my view is to stop because I'll tell you, I mean, at 72, and I know it's going to take a while to come back, but I would love to experience libido again. I really would. And hopefully
your wife probably would love you too.
she's an incredible partner in all this. She really is. I have
sure.
an amazing wife.
You probably know, Don, that we also have a caregivers meeting in case she's interested. In my particular case, which is very much like yours, I started out as a Gleason 4+5, and I had positive lymph nodes in the pelvis, just like you did. My tumor board recommended 24 months of Lupron plus abiraterone. At the 24-month point, I was non-detectable at that point, and they took me off medications. I'm now at something like 30 or 31 months. I'm no longer non-detectable, but my PSA levels are very low. Give you an idea about what one other person experienced.
Thank you for that that description. That helps a lot.
And my 2 cents for what it's worth as a non-expert is that thing next to where your prostate used to be is probably not PSMA. I mean, there's probably not prostate cancer, but they will continue to watch it. Obviously, from the number of scans you've gotten, somebody's taken a very active look, and will continue to do so.
That's me. I more or less demand those scans. I mean, my radiation oncologist is anti-scanning because it happens. I become a pain in the ass because of the scans. He doesn't like that, but I demand the scans.
No,
It's because
that's
of
good for you.
Yeah, it's because of false positives that they don't like them. But yeah, we want to know what's going on.
I'd recommend, just sort of to wrap up, I'd recommend a couple of things. One, I'd go back to your doc, Minocha. Yeah, Minocha. and I'd ask him where he gets the 36 months from. Ask him to actually show you where the 36 months is, because none of us know it. Now, that said, there are so many stampede arms that there could have been a stampede arm that had 36 months in it, because there were probably 15 or 20 stampede arms. Len and Dr. John are better at knowing at these trials than I am. The second thing I do is, as I said to you when I wrote back to you, I definitely would recommend considering Dr. Belusic. We really we like Belusic. There are people in this room today who have seen Belusic. They may want to say something. We think he's very solid. We get great reports when people go to see him. They come back glowing, and he is a really well qualified genitourinary medical oncologist. From looking at Minocchio, when you sent it to me, I think he lists GU as one of his interests, but he also lists a bunch of other things. He's really more of a general. And Belusic is at Sylvester. He's really great. He's downtown, so you will have to go downtown. Sorry, can't do anything about that. But I think
That's
he's
no big
worth.
deal. It's 40 miles away.
Well, I'm glad you say that, because we do have people in your area who tell us it's a big deal. But that's how I would look at it, and I would say Belusic is worth the drive.
I'll agree
I'd
with that
second.
100%. 100% Don. Belusic is my man. He's the finest, highest quality guy.
Thank you so much. And I do want to thank Rick for your courtesy, Dr. John for your courtesy. I really, really appreciate your help.
Well, welcome to group and come back in person anytime. We'd love to hear how
Come
everything
on back.
turns out.
Yeah,
And
and
by the way,
reach out to David Muslin, David M at AnCan.org. He's in Boca. Maybe you can get a cup of coffee with him. He's got much the same, bit of a similar background to you, slightly worse, but he's now on monotherapy darolutamide, and those are other options. Sorry, Dr. John, I didn't mean to interrupt you.
by the way, in terms of where PSMA scans may light up in the absence of prostate cancer, if anybody wants, write to me, and I have a nice article about that. And also regarding that, did anybody pick up the error in this week's introduction?
The esophagus?
Yes. Yes.
I
It
was
was
going
a
to email you privately, but I figured John
no
probably
need.
already knows.
Yeah. It should have said, well, the original version of it just said that you might get dry mouth, but it went through some editing between me and Rick and ended up with that mistake. It should have said the salivary and lacrimal glands. Okay. I'm going to get.
I take responsibility probably then. I should have said the salivary glands and not the esophagus. I take responsibility. It was not Dr. John's error. It was my error. Okay.
It was just a test. I did get an email
Sorry.
I got an email from Dr. Bob about it.
Okay.
Mike, uh, let's see. Okay, Mike, we're going to go through the same thing with you, except I have to ask you all those questions because I don't already know the answers, okay?
Okie doke.
Is that all right with you to do that today?
That's just fine.
Okay. How old are you?
74,
And where do you live?
Boulder, Colorado.
Ah. And tell us about when you first got diagnosed. How long ago, and how your prostate cancer was discovered.
Well, the first diagnosis was at the end of December last year, where I had a PSMA scan
Boy, that
The-
can't have been the first thing, can it?
well, that was the first diagnosis.
Oh, interesting. Okay, go ahead. Sorry for interrupting.
What preceded that was a couple months earlier, I had a stomach flu. They took a CAT scan of my stomach and noticed that there was something concerning about the base of my spine, the bone. And at about that time, I also went and had my yearly physical, and my PSA at that time, last October, jumped from about what had been my, shall we say, normal in the high fives to low sixes, and it jumped up to almost 12. So, based on uh, those two test results, that is why the PSMA scan was ordered. Now, earlier in December, before the PSMA scan, I had a prostate biopsy from a new urologist. He did a 13-core prostate biopsy, and that was after an MRI of the prostate. And he did one extra core in an area of concern that showed up on the MRI, and the 13 cores came back benign. And then he ordered the PSMA scan, which showed it lit up in my prostate in that area of concern from the MRI. And the PSMA scan also lit up in 3 places in my sacrum, S1, S2, and an area called the sacral ala. Those areas in the sacrum had an SUV max of 4.8, and the sacral ala an SUV max of 3.2. So there was this um, assumption of metastatic prostate cancer, but this confusion because the prostate biopsy came back benign. Subsequently, the urologist was quick to say he wanted to do a saturation biopsy of the prostate with up to 30 cores, and he would follow that up with removing the prostate and then do treatment. I really had hesitated about that and received word from fellows, um, in fact, on this group and others, that that's probably not the way to go to remove the prostate if you have metastatic prostate cancer. And so I went to a local oncologist with Rocky Mountain Cancer Center, and he is suggesting a bone biopsy of the sacrum under CAT scan. The idea is, let's get a definitive under the microscope confirmation of prostate cancer before treatment. My question is, what's best at this point in time? Should I have agreed to the saturation prostate biopsy? Should I agree to the sacrum bone biopsy? Should I agree to none of the above? Some people have suggested to me just start ADT and see what happens to those hotspots on the PSMA scan, see if they reduce. And ask away any other questions you might have.
Okay, we'll get to your questions. I'm going to ask you. So we actually we have no Gleason score then.
Correct.
What's your most recent PSA?
It was almost 12.
Okay.
It had jumped from it had jumped from 5.8 to 11.9 or 11.8 in 1 year.
Okay. And so no treatment of any kind at this point.
Correct. In the
Oh,
past, when my PSA went up somewhat, like I had a prostate biopsy 10 years ago and it came back benign. And then the urologist put me on an antibiotic. It went back down. And there's been a couple times over the last 10 years where my PSA jumped by a point or two and into the sixes. And I was on antibiotics. It went back down some. But this jumping up to 12, it had never reached that number.
have you had any uh, cheek swab or blood test to check whether there's any genetic abnormalities?
I just received the promise
You're going to do promise?
kit.
Okay.
It just came yesterday, and
Okay.
I'll send it back tomorrow.
Are you familiar,
My comrades, my
students, are you
comrades,
familiar what promise test is?
I'm sorry.
I'm asking the students if they're familiar with promise. Promise is actually a study, not a commercial diagnostic test. But in the process of this study, they are taking promise is cheek swabs, isn't it? Yeah, they are taking cheek swabs and looking for germline abnormalities. They're collecting a gigantic database, but we, unlike a lot of studies, we get to use the information clinically.
So for the students, Promise is being sponsored by Johns Hopkins and University of Washington. It uses color, and it's a free test available to anybody that's been diagnosed with prostate cancer, and includes a genetic counseling, a virtual genetic counseling. So we often recommend it. I mean, it's a solid test. So.
Mike, are you a veteran?
No, I'm not.
Okay. Okay. We've got our basic history down. Len has a question for you about your early biopsy, whether they did any tests on that. Len, do you want to ask your question?
Yeah, I mean, basically, you just asked it, John. So Don, why is it that you don't have a Gleason score after they did a 13-core biopsy? They could have done pathology on any one of those cores to see what your Gleason score might be.
They did, Len. They were all benign. They all came back benign.
Correct.
I thought I heard John say we don't have a Gleason score.
Well, we don't have a Gleason score because all 13 cores came back benign.
Well, you're both right. You know, they looked at it and they considered him a 1+1 or whatever you consider it when it's totally benign, I suppose. So I guess in a way I was wrong. We do in retrospect have a totally benign Gleason score.
Wouldn't they be doing another PSA on them, like, frequently? October was a long time ago.
You're suggesting I have another PSA?
I'd want to know if it's
You know,
still going anywhere.
It's 3 months.
I'm
Can I make a
I'm
comment?
thinking.
Rick.
Yeah, I'll yield to you in 1 second, Peter. What is puzzling me is that this 12 that you had in October, have you had a PSA test since then, or are you just saying that was the last PSA test?
That was the last one.
Okay, you got to get another PSA test. And, your Euro, to be honest, should be shot and quartered. I mean, it's just outrageous. And one of the reasons why is because if we see a movement in that PSA, then we know something's going on despite. I mean, this ain't brain surgery, Mike. I mean, he's looking to figure out what's going on. And so, tomorrow morning, go back to the same lab. I mean, we can't give you medical advice, but if it was me, I would go back to the same lab as October, which is 3 months ago now, and see where my PSA is. Second thing I would do, as I've said to you, is get your ass out of that urologist as soon as you possibly can and get to you really need a genitourinary medical oncologist. There is one, as I wrote to you at Anschutz, but she's okay.
Elisabeth Heath.
She wouldn't be my choice. So then it gets into, are you willing to travel? And if you're willing to travel, we can recommend some good docs. But and they will counsel you. Now, it's not unusual today to debulk, but they usually don't do it right away. Although I have seen it, and there was actually a clinical trial about 4 or 5 years ago that was debulking right away as they put you on hormone therapy. But I think that you need to get good counseling, and you probably need to get on hormone therapy sooner rather than. And that hormone therapy should be supervised by a genitourinary medical oncologist. And then maybe after a while, and there are guys who have done this in this group, they will debulk, and you can debulk either with surgery or radiation, but most often it's done with radiation today. And this whole debulking phenomena is relatively recent, like the last 5 years. We saw it before then, but it wasn't that often. We saw it mostly surgically, and surgically at Memorial Sloan Kettering, surgically at Mayo, in Rochester. They favored it. But today we see it a lot more often, usually from the radiation oncologist. It may include the whole pelvic girdle. It may not. That part is a bit controversial, how much radiation. But my bottom line is you've got to get yourself to the right doc, and this doctor that you're using is not. Peter, Mr. Boulder.
Yeah. So, unfortunately, Mike lives in the rabbit hole of Colorado, which for some odd reason does not have the greatest care for prostate cancer. Mike and I talked pretty extensively the other day. There's a couple of things that haven't been brought up. I, I gave him the same suggestions that he needs to find a really good doctor. I think the thought of doing a bone biopsy is actually pretty good at this time. It is a little bit invasive, but just to have a definitive answer of what's going on there, is it prostate cancer? And then use that biopsy and for sure get some somatic testing done. Mike didn't mention, but he has pretty extensive cancer in his family. Brothers, father, lung cancers. Anyway, so if the germline test does not show anything, it would probably be a smart idea to lean on a good doctor to sign you up for somatic testing and see what's going on, whether there's any actionable genetic mutations there that might be driving this, because it's an oddball situation. It's not, it's not following the normal course. So I agree. He needs to find a really excellent doctor, whether that means MD Anderson, whether it means Omaha, whatever. You might have to travel a little bit. Usually you only have to make one visit and then you can do the rest on the phone, because urinary medical oncologists don't need to see you every month in person, but they probably initially need to see you to sign you up. So that would be my take if it was me. And it's been me. I mean, I got out of Dodge 10 years ago and traveled 2,500 miles to California from Hawaii because I knew I couldn't get good care here.
The family history of cancer, in particular, is my mom, who was a heavy smoker from lung cancer. She passed, but my dad passed from stomach. His fraternal twin, also from stomach cancer, and their mother, my paternal grandmother, died from stomach cancer. So that's the strongest um,
Hmm.
genetic component.
It's pretty compelling. Who here has had a bone biopsy, just in case Mike is anxious about what that's like?
I am anxious.
Joel, would you like to tell Mike what it's like?
Yes, I went to NIH for a clinical trial for PSMA PET scan at the time. That was like 4 years ago or so. And they, because I had sleep apnea, they wouldn't put me to sleep. So they decided to do it with lidocaine. And basically, they have to put a drill. Mine was in my left iliac bone, and they had to put a drill through my skin, but they do that through a needle. I believe the drill is in the needle. It's a big needle, obviously. And then when it gets to the bone, I didn't feel anything on the skin. Didn't feel the needle going through at all. When it got to the bone, I could feel it, but it was bearable. It was not, excessively painful. I think Len has had a biopsy at NIH too, haven't you, Len? Did a bone biopsy you got?
Yeah, it's almost identical to your experience, Joel. I was also, well, mine was right iliac bone, and it's not very painful. I didn't have anesthesia at first, and they said, well, if you get uncomfortable, just let us know. We'll put a little fentanyl in the IV. So after they were banging away, trying to get into the bone, my body is shaking, and I'm going, "Hey guys, I think I'll take a little of that fentanyl." Um, but I mean, it was never painful, really. I was just getting a little freaked out, I think.
The
But
amount of information to be gained is really tremendous. When you think of
yeah,
the pathological and genetic information that you'll get from that biopsy, very great.
yeah, the problem is, John, that what they have to do to process the bone, uh, to dissolve the bone away so they can get to the tissue. Once they take out the plug, they say that it can destroy
Yeah.
a significant amount of the tissue for analysis.
So you might get a
Yeah, but
false negative.
Len, what's interesting here is they just want to check and look at rather than wanting it for the sequencing, they actually want it just to see if they can see prostate cells. As a normally, yes, the maceration is a problem because it could destroy the mutations. But here they don't really care so much about the mutations. They're taking this plug because they want to see, is it prostate? Are these prostate cells or not? Which is a little unusual, but of course the side effect is that you'll get your mutations too. I just want to say we sort of got to move on, but I just wanted to say to you that if I was going to Houston, there are a couple of good options at MD Anderson, but I think I would probably go to Eleni Evstathiou at Houston Methodist rather than to MD Anderson. We like Dr. Korn very much. Jim Ward's on. He's a patient of Dr. Korn, but it may not be easy to get an appointment with Dr. Korn. We can, definitely. Eleni Evstathiou was 14 years at MD Anderson before she went next door and started a group there. But that's if you're thinking of going to Houston. There are other locations where there are some very good people closer to you, Chicago, for example. But
Right.
we can guide you, Mike. if you decide that you want to move, and we can get you. I'm going to have dinner with Elaine on tomorrow night. So, I feel like you need to do something pretty quickly.
Right now, I
I,
have the bone biopsy scheduled for February 1st.
okay,
Oh,
well, I think that's good. And who is supervising that bone biopsy?
When you say supervising, I'm not sure what you mean.
Who ordered the bone biopsy?
The oncologist, Dr. Poole at Rocky Mountain Cancer Center.
Right. So the one thing I can tell you is you don't want to stick with him. It's not a bad idea to have a bone biopsy, but you don't want a general medical oncologist. I mean, yes, it's a good move, nothing wrong with that, but you've got to have a medical oncologist who specializes in genitourinary medical oncology. Specializes, not somebody who does prostate, because this field is moving so quickly, and it's hard to keep up. And you heard with Don Rogers just before, and we feel very strongly about that, um, because we see all too often men not getting treated well enough. So by all means, pursue that and go through it. And Feb 1st is good, but you've got to get your ass into a real good GU med onc.
A
And
friend
if you make,
went,
make the choice, if you tell us where you're willing to go to, will give you names and recommendations. A lot of times we do know them. And, like if I know that you wanted to see Elaney, I'm going to say, Elaney, I'm sending a guy down to you. Can you get him in quick?
a friend of mine went, has gone through metastatic prostate cancer and had tremendous results with a Dr. Kwan at Mayo. And
Stay away. Stay away. That's
why,
my that's my personal. Dr. Kwan is not a medical oncologist. He doesn't he does not prescribe standard care that a medical oncologist would. And I'm very glad your friend has done well, but this is definitely not. Um, he's not a doctor that we would recommend. If you want to go to Mayo, the doctor to go to see is Dr. Oliver Sartor, who is excellent, who is a medical oncologist. He will be one of the docs in our webinar next week, so you can get a feel for him. He's really good. We like him a lot. So if you want to go to Mayo, that's the doc to go to. But I got to tell you, you got to give your right testicle if you're with Dr. Kwan to get him to refer you to to Dr. Sartor. We have somebody on the call right now who has been with Dr. Kwan for many years and eventually managed to get a referral over to Dr. Sartor. But stay away from Kwan.
I'm willing to go wherever there's a good GU.
okay, good. It'll benefit
Well,
you. You have a strange case there, a little complicated, and you need an
right.
expert.
Be in touch and tell me. Sartor's a good option. Dr. E is a very good option. There are people on here who see her and they love her. Dr. Belusic is a good option. There's a good option in Chicago with Dr. Shmulowitz. You have to tell me where you're willing to travel to. You tell me where you're willing to travel to, and we'll come up with a name there or somewhere close.
May I email you, Rick?
Yeah, but I'm going to be pretty tied up over the next 3 days, but the sooner the better, because if I see one of these docs on the floor at GU ASCO over the next 3 days, I'll pull them aside and say, hey, we just sent somebody over to you. You need to get them in quick.
Thank you.
Well, welcome to Group Mike. I'm going to go on to some of the regulars. Rick, if you have a chance before while I'm going on, would you mind putting a link to Promise in
It's
the?
done.
Oh, you did
It's
already.
done.
Okay, thank you.
Yeah.
Let's see. How about Mark Valens? What do you got going on, Mark?
Oh, just a quick update after
Okay.
I'd had after 4 years of cancer having disappeared, it came back early November, and I have a metastasis on my pelvic bone, and I actually finally I'll start radiation on that tomorrow, um, and that my kidney failure came about because of my urinary problems, and the urine backed up into my kidneys and gave me acute kidney failure,
Hmm.
and I'm still dealing with that. Um, I just saw my local urologist today, and then I'm working with Dr. Breyer at UCSF. But one thing I heard today, I was just wondering if anybody ever come across this. I did a retrograde urethrogram the other day that shows that where the urethra goes through what's left of the prostate, it's tiny. It's really compact, and that's probably where my problem is. And my urologist today said, even though I had radiation to the prostate for 7 weeks, she says might consider doing a prostatectomy. Have you ever heard of doing that? It's my image, like it's an all shriveled up thing, but I don't really know. Has anybody heard of taking a prostate out after it's been radiated?
Make sure you have the best surgeon in the world.
So
Don't
look,
go to your neighborhood guy.
No,
okay.
I'm
So
This
the
is
answer is yes. The answer is yes. We've heard of it. It's called a salvage radical prostatectomy, and it's done occasionally. And and there are docs who are doing it. For example, you could go to Peter Carroll. You'd be in great hands with Peter. And again, I may see Peter tomorrow night. I'm hoping he's going to join us for dinner. And it would be easy for us to get you to Peter, and you have a history there. That said, I've never heard of it um, recommended to solve a urinary problem. And that's something, if I see Peter tomorrow, I'll ask him about how frequent that is, how unusual it is to solve a urinary rather than a cancer issue, because that's what they're talking about in your case, I think, Mark.
well, I just so I went to the urologist today to get the cystoscopy, and then I just had the retrograde urethrogram and the voiding urethrogram, and sending all that stuff to Dr. Breyer at UCSF, and I'll wait and see what he says, um, because he's the one that told me he could build me a new urethra with cells from the inside of my cheek.
Oh, right. So now Dr. Breyer is an interesting case because he's actually not he's not an oncologist. He's not a urological oncologist, but he is the new chief of urology. He replaced Peter. Peter stepped down, and he is the new chief. So he's really. So again, if they were going to do some sort of reconstruction, then yes, either Brer or Peter, both would be great.
Okay. Well, we're setting that information down there, and I've got a telehealth call with Dr. Bear next week. So,
Okay.
anyways, I'm still recovering from the kidney failure that knocked me way back, but
But you
I'm
are
doing a lot
recovering?
better.
I mean, for you to be recovering must mean that urine is passing.
Yeah, we finally we finally got the catheter out um, after 6 weeks or whatever, and I'm
Good. Well,
peeing on my own now.
okay,
I
great.
still have the
Great.
nephrostomy tubes, so I still got two bags attached to me, but mostly I'm peeing on my own, and
Good
that's a
job.
relief.
Great. Oh, that's great. That's great. That's great. That's great to hear. That's
have you
great.
had has Dr. Sinahara looked at you at all?
I don't know who that is.
You might want to book an appointment with him. He's a pretty amazing guy. He sees things with ultrasound and stuff that nobody else sees. He he saved me from getting my bladder removed years ago. I mean,
Yeah.
he's a pretty savvy guy. He's with
Where's
urology.
he?
He's with
So
urology, fourth floor, up on
he yeah.
Mission Bay.
Yeah, I think that you might. I think the way to do this, you don't. I would not recommend you go booking appointments with Dr. Shinohara when you're seeing Dr. Brer. I would. What I would say is you might want to ask Dr. Brer, do you think that Dr. Shinohara would see anything that he hasn't spotted, or Dr. Carroll would, if it's worth involving Dr. Carroll. Dr. Shinohara, his claim to fame, he's worked on a bunch of us in here. Peter, he's worked on me, he's worked on a lot of us. His claim to fame is that he does amazing stuff with the color Doppler. And now we don't really use the color Doppler so much because the technology has moved on beyond it. But there are certain doctors at UCSF who still won't do any surgery without him. But again, it's a little different it's not as appropriate because he's using that color Doppler to spot cancer. And your issue isn't cancer. Your issue is that the urethra is compromised as a result of the radiation. So I don't know if Dr. Shinohara is going to be able to do that much for you. But that's the background on Shinohara. If we were suspicious that you had cancer in your prostate, yeah, I would say good idea.
Yeah, but
But
I just had the PSMA and it's
right.
scan, and it's all I have is this one met in the pelvic bone.
Yeah, so I don't know. I'm not sure I'd agree with Peter that this is a right thing for Katsuto Shinohara to get involved in, but it's worth discussing with Dr. Brer.
Yep. Okay. Thanks, guys.
You're welcome. Thank you. Dr. Jack, what do you got?
I only have two questions. You already answered the first one, having to do with the ASCO meeting, so I appreciate that. I have a question. It has to do with side effects. I've only been 9 months on the doublet thing, and I'm having something happen. I don't know if it's low testosterone or the medication or stopping the supplements that are carrying me to so many years. But I have more stiffness and arthritis. I can't even open and close my hands. I've got trigger fingers. My knees hurt, my ankles hurt, my shoulders hurt. More inflammatory stuff going on than I've ever had in my life. And I don't know if this is what happens to people on low testosterone. There's something protective about testosterone that keeps you from being so vulnerable to this kind of. You're shaking your head, Rick. Help. Thank you.
Yeah, because the answer is a lot of us who have been on androgen deprivation therapy are very familiar with this. I mean, me personally, my arthritis, trigger finger, all of that really started up, and I was 56 at the time. And the problem is, it's never gone away. That's the problem. I mean, my fingers lock up all the time now, all the time. And it's very difficult, as you know, if you're holding something and you don't have another hand, like you can't open your fingers anymore. But I personally think, yes, there is definitely an impact. I'd be interested to hear what the Brains Trust thinks and whether they feel it's related to the hormone therapy. I was pretty lucky. I didn't have a lot of pain, but we hear of people complaining of muscle pain and arthritic pain all the time.
Thank you. Anybody else or just Rick?
Yeah, Jack, I've had 3 trigger finger treatments with, they just inject prednisolone.
Yeah, I've had
Went
that.
away. It went away
I know.
each time. Very
But
simple.
nothing more, no surgical procedures or anything like
No
that.
surgical.
No collagenase or any of that stuff.
No what?
Collagenase, the stuff they
Oh,
use for Dupuytren's.
right. No, nothing. Just prednisolone.
Okay, yes. Well, I'm going to have that done when I have my
Yeah.
knees injected. Yeah, and just the overall feeling of, stiffness. Getting up in the morning, it's like such an ordeal. I'm like, and by the time I get moving, I feel better. But without moving much, it's really amazing. I'm getting physical therapy right now, which really helps. But
You think it'd be worth seeing a rheumatologist?
I see a rheumatologist every 6 months.
Oh,
I see my knees injected. I talk to them about it all the time. I've been tested for, all kinds
okay.
of collagen and rheumatoid and everything else, and nothing shows up. So it's whatever, a lot of wear and tear that's culminated with hypotestosterone, whatever. It's just made it worse. I used to take a lot of supplements, tons and tons. I stopped because of all the other medications I'm taking right now. I was afraid to take too much, mix it up. It's going to throw off the liver metabolism and everything else. So I don't take all the stuff to prevent this kind of, you know. All right, guys, thanks. Thank you,
Victor,
Rick.
Vic, do you have a comment? Is it about Jack's question or something else?
Yeah, I was going to ask Jack, did I hear you say you're on doublet therapy?
No, doublet. No, I'm doing darolutamide and Orgovyx for, you
Okay,
know,
yeah,
yeah.
I was going to say if it was Abby, maybe it's
No,
because adrenal output is being lowered, but I don't know that, Daryl would make that much difference.
that's a good question. No, it's darolutamide, and Orgovyx. Thank you.
Vic, why don't you keep the floor and tell us what you had to talk about? And I'll get Peter.
Peter had a comment.
It's not worth it. I was just gonna say, if you have trouble getting up in the mornings, just don't get up in the mornings. Get up in the afternoon.
That's the best thing I heard of all day.
Yeah, I also have insomnia from all of this crap too.
I can hardly
So,
get up in the morning, and that's after 10 hours of sleeping, and then I have to take a nap. I hate this stuff. Okay,
geez,
Vic.
amazing.
Okay, had my third and I guess final infusion Provenge on Friday,
Ah,
and it appears to be a cumulative effect. Uh, Certainly, the first time I had it, hardly any reaction. Second time, a little bit of reaction. The third time, I felt like I had a fair dose of the flu for about 24 or
Yeah.
36 hours. So that was my reaction to it. But the one thing I wanted to mention about it particularly was for some reason my platelets are extra sticky. And the tech that was running the blood machine doing the collection, the first time I went in, my platelets clogged up the machine. And
Ooh.
the tech told me in 11 years she had never seen that on the machine, where the platelets, got so sticky that they clogged it up. So for the rest of the collections, extra anticoagulant is what she used. So just a heads up to anybody that winds up with Provenge, and if you have a problem like that, maybe if they've got extra anticoagulant they can add in, you might prevent you delaying your first treatment or something like that. And other than that, I had a question about PSA, SMA, avidity for bone versus soft tissue. Is it pretty much equal across the board, or are bone mets more avid than soft tissue mets? Or anyone comment on that?
Um, that's a great question. I've never thought about it before. What I do know is that the more advanced and aggressive your cancer is, the higher is um, the avidity, provided that it hasn't morphed. Once it starts to morph, then it stops making PSMA. But I will be with the Telix people tomorrow, And I'm going to make myself a note, and I will ask the Telix folk whether there's a difference in avidity between soft tissue and bone tissue. Does anybody have an answer on that one, or anybody know anything about that one?
I've never heard of any difference. Some guys have only bone mets, others have only lymph nodes lighting up. I think I don't think it has anything to do with PSMA is PSMA, and so you have an antibody to PSMA wherever it is, it'll attach, light up.
Vic, I'm a little uncomfortable with that idea of your platelets being extra sticky, because if that translates to hypercoagulable, then that could translate to clots. Could you
I felt
just
the same
find
way,
out a
John.
little more about that from your doctors? If you have some kind of coagulopathy or something that might make it more likely to clot, I think you should know about it.
Yeah, thank you. That's a good suggestion. I think
Mhm.
my son is the same way. So perhaps it's some sort of a genetic situation, but he was on a platelet collection machine one time and had the same experience
Wow.
when he was donating. And I'll definitely look into that.
Okay.
Yeah.
Are you on any anticoagulants or at least an aspirin every day, just
No,
prophylactic?
not even taking aspirin.
Oh,
Yeah.
I mean, imagine if that's happening in vitro, what could be potentially happening in your body. So I'd see a hematologist in consultation.
Mm.
Uh,
Yeah,
Yeah.
that
Yeah.
bothers me a little bit too.
Definitely talk to my GP about a referral to a specialist, to blood specialist on that, and also, uh, yeah,
Vic, what's your
Next,
platelet count?
platelet counts is always in the normal range.
And by the way, Vic, it is not unusual to feel a bit fluey. So basically, what you went through, yeah, fairly normal.
Yeah. I'll add one thing too, that with the Provenge, they do caution to watch for clotting as a side effect. It's not a
okay.
common side effect, but it is mentioned that the treatment sometimes does cause clotting.
Oh,
So
okay.
maybe the overall procedure, helps to lend towards that a little bit. But like I said, this nurse at the Red Cross where they did the collection, she said in 11 years of running the machine, she had never had it happen to her, and
Hmm.
it just so happened that within that same week, she had one other guy come in, and the same
Oh,
thing happened, which was really strange. She said, but I will definitely talk to my GP about a referral to
let's just
a
make sure that
specialist.
let's make sure it's the Provenge and not you or your family history.
Yeah, thank you. Appreciate the suggestion.
Genetics counselors, any comments about two people in the same family having excessively sticky platelets? Okay, we'll look into it. And next guy I got is Peter.
Okay. Well, we'll label this one. If it walks like a duck and talks like a duck, it must be the odd duck. Moi, Peter. So, in deference to the students attending this, I praise you for wanting to work in this field. Uh, I am a Lynch syndrome patient. I've got a mismatch repair gene, MSH6. I've known this for quite some time. It is not a common mutation for prostate cancer, and and I'm germline on that, and there's no way to know if this is definitely what's behind it. But I've been through the mill in terms of treatments, surgery, different kinds of radiation, ADT, chemo. I just finished a year of immunotherapy,
Hey,
which I
Peter,
qualified for.
Peter,
Anyway,
hold on. Rick's
Peter,
got a,
just
Rick
hold
wants a
up.
moment.
The whoever just joined us with MS, that meeting starts in another hour. It will. I don't know what time zone you're in, but it will start about an hour from now. So
Okay, great.
please come back to the MS. We'd love to see you in the MS group. This is a prostate cancer group. You can stay if you want. You're very
Gotcha.
welcome.
No,
Okay.
thank you very much. I appreciate that. Thank you. Bye-bye.
Bye.
Sorry for the interruption, Peter, and
Sorry, Peter.
thanks for
okay,
giving
I'm
the
not going to go
students
through the
some
whole
background.
history here, but I want to update you here.
But do a
So
little more genetics than you normally would, because we
yeah,
have
so
them in the room.
I'm rapidly reaching another decision point. I met with my local doctor for the last time last week. I did a PSMA scan last Friday, which I got the results from this morning. That's been my fourth PSMA test. And I'll tell you about that in a second here. So my last blood test was an oddball one. So for the last 3 months, my PSA has been holding around 0.7 to 0.8. And then a week or so ago, it jumped up to 1.99, so it doubled. And that's got my attention and my doc's attention. So something might well be on the move again. I'm not panicking. I'm hoping to get another couple of months out of this. I've been off of Keytruda, off of immunotherapy now for over 6 months, and I plan to keep going that way. I meet with Dr. Schultz, who ordered the PSMA scan on Thursday this week to talk this things over with him. My local doc, well, first my expert doc in Minnesota, in Tanarakis, he's got me on prednisone right now, and that seemed to have fixed the colitis issue that I had. He was familiar with that, and so I'm weaning off of that down to 10 milligrams now for another week, and then 5 and 2.5, etc. So I'm okay that way. But he said if it's, let's see what the PSMA scan looks like. Let's watch the next blood test or two and see what your PSA looks like. And he said hold off any kind of treatment for at least a month or two. And he thinks rather than go on immunotherapy again, I should go on a PARP inhibitor or whatever, because he doesn't think I can probably tolerate the immunotherapy again if I go back on. My attitude is that it's a known rather than an unknown, and maybe I could do it and at least try it and see what happens. My local doc thinks I should go on ADT, and I'm not buying that right away. And he's leaving anyway to go to Minnesota. I'll see what Dr. Schultz says. I don't think anybody's going to panic. I just want to bring in information and kind of weigh these things. He says, well, if I go on a PARP inhibitor, I should do ADT with it. And I don't know. I'm not keen on jumping onto ADT again. I've been off for a year and a half, and I'm enjoying the holiday. So the other anomaly is that on my blood test last week, my red blood cell count came up in the normal range, low, a little over 4, for the first time in 8 years. I've been anemic from the get-go. For 8 years ago, it went south. My hemoglobin and hematocrit are not in the normal range, but they're just below normal. For the first time, the highest they've been in 6 years. So what do I attribute that to? I have no idea. So I've done a little bit of research. I've got to do some more. So my PET scan showed the same issues that it's shown the last 2 times. It says 2 PSMA avid soft tissue nodules, left side pelvis, suspicious of peritoneal lesions. So I've known that for a while, that I'm an odd duck. I've got something going on in my peritoneal cavity. I did a biopsy years ago at St. John's in Santa Monica, and it came back positive for prostate cancer. So it's not peritoneal cancer, thankfully. It is prostate cancer, but in the peritoneal cavity, which is very strange and odd for a guy, and much more common for a woman, but not for a guy. And peritoneal cancer can be fatal, but this looks like it's not peritoneal cancer. It looks like it's
So,
prostate cancer.
Peter, was that the PSMA result? Do you have
Yes,
that? That was the
yes,
PSMA result. So they didn't
no,
see anything really new in the PSMA. Now,
nothing, nothing.
question for you. Haven't you shown a somatic BRCA mutation at some point?
Yes, and that often drives peritoneal issues.
So,
So that's
I mean,
probably why they're thinking olaparib.
well, you know that how long ago was that somatic BRCA?
Let me think if I can remember. It was after my after they did the biopsy of my peritoneal cavity. So it was I think December of 2019.
Well,
I don't have any other tissue at this point to do
okay,
it on.
but maybe what I would do when you speak to Antanarachis or to Schultz is ask them to order a liquid biopsy, and let's see if you still are showing a somatic BRCA mutation. Because if you are, then yeah, it would add reason to considering a PARP.
Yeah, that's kind of where my thinking is too. But I just want to again, I'm in the information gathering thing. I'm not panicking. I'm writing this. I'm well aware of this journey, and
Okay, but
it's just a
is a
strange.
liquid biopsy in your plans or not?
Yeah, I'm thinking of it. My PSA is up around 2 now, so I could qualify, I think.
That's what I would do. I'd get that liquid biopsy as part of the information if it were me.
Okay, I'll put it in my questions for Schultz for Thursday.
Now, Peter's a guy that has prostate cancer in various different locations, right?
No,
Which are,
this is it.
oh, this
That's
is
it.
it.
Yeah,
Okay. So
This is
a
no
reversion.
no bones, no soft. It's just a soft tissue in my peritoneal cavity.
Okay. So
I
a
mean,
reversion to
wasn't my
wild.
prostate.
Yeah. So I implied in Rick's idea is maybe there could be a reversion to wild type, right? But that's not
yeah,
totally out of the question if it's all located
right.
in one spot. Okay.
That's right. That's right.
Uh,
And
Good.
Peter's never had much metastasis, and he's never had high. He's never had high PSAs. He's never had much metastasis. He does have this germline MSH6 Lynch, and he also is MSI high, so he was a good candidate. But whilst his disease has been around for an awful long time, it's always been controlled. Thank God, we've never seen any extensive distant metastasis other than in this peritoneal cavity.
No, I did have a couple of lymph nodes near my heart, and I did that with I zapped
Oh,
them with a
right,
proton beam. Yeah, but
right,
that's been it. Yeah,
right.
yeah.
What about Peter's other question? When we read studies with PARP inhibitors, the person is always on ADT, aren't they?
I don't know.
So do we even know about PARP inhibitors in the absence of ADT for BRCA2 mutation prostate cancer?
You know, uh, Janssen now makes a Kega. No, is it Janssen who makes a Kega? I think it
Uh,
is Janssen who
yeah,
makes a
yes,
Kega,
yeah.
which is a combination of abiraterone and not talazoparib, niraparib.
Right,
Their PARP.
and no classic ADT.
Well, I think again it's going to be the call of somebody like Otanarachis, whether he wants to add the ADT or he doesn't. It sounds like he does, but I would be saying, why?
Exactly.
If the abiraterone is doing its job, who was it last week who said, well, if the abiraterone's doing its job, why do you really even need ADT? Why do you need an LHRH? And I would challenge Antanarachis.
Yeah.
Questions like that are finally dawning on us, aren't they?
And
Right, Len?
I've still got a bottle of Nubeca. I mean, I could go on darolutamide
Yeah.
and then try that again. I don't know, as monotherapy if I need to. I mean, I've been feeling great. That's where I'm digging my heels in. I mean, a year and a half of off of ADT and 7 months off of immunotherapy. I mean, I'm feeling my oats right now, so I'm a little bit reluctant and cautious about my next move.
Yeah, I think that's remarkable that your red blood cell count, your H&H are just about normal now. Because I remember you were very low on the hemoglobin. You were down like 9 and change.
Yep. Yeah, below
So
9.
that's
Below 9.
fantastic. Have anyone ever heard of combining a PARP inhibitor with immunotherapy? For some reason, I'm thinking there was a clinical trial with that combination.
Sounds
Maybe
rough.
talk to your doc about that.
Right. Yeah. So this is
My
one of those.
my concern, Len, on that is it could be a bit toxic because those parts are pretty toxic, can be pretty toxic.
Right.
And
so can Keytruda.
exactly. So putting those two toxic drugs together, I don't know. I mean, that's the one issue with the PARP inhibitors that bothers me is they may work and they may work as we know they really only work if you have BRCA, maybe BRCA1, BRCA2, maybe PAL. It's really questionable with ATM, and it's certainly not on the table for the rest of them, as Len knows better than anybody because he's done the studies. And we heard Neil Shore wanting to hand out PARP inhibitors like candy. Oh, well, give everybody a chance. If they're sick, then yeah, give them a PARP inhibitor. No, PARP inhibitors are effective if you've got the right mutations, but they can be damn toxic. We've seen the guys, and especially with you preserving your blood counts right now, those PARP inhibitors are going to play havoc with your blood counts.
Yeah, Carl had a rough time with them. I know that.
Yeah.
Yeah.
Listen, I'm going back to Colonel Susan's husband, Ron Silvera, 6 years ago, 7 years ago.
Yeah. Yeah, I'm cautious.
Well, my thinking was that yes, they're both potentially toxic, but they're not synergistically or complementary toxic. They're the olaparib could be immunosuppressive on the bone marrow, but the immunotherapy is an immune stimulant, so it could actually help mitigate the immunosuppression of the PARP inhibitor. But there's no science behind what I'm saying. I'm just, it sounds logical.
Right. Yeah, and I'm a little bit cautious. As you guys know, I've got numerous doctors weighing in on this, and nobody really has the definitive answer. But I'm gathering the information. My another point of caution is I have to start with a new doctor here, who just moved to the islands, who went to medical school in Nevis, which isn't a high-ranking medical school in the U.S.
Well, but
It's in the Caribbean.
Peter, as we've said before, and I know I don't want to offend you, but you've got to manage your doctor. You have got to manage your doctors. There's no point in going into all these doctors and sitting down and then and what they tell you, giving equal weight to what each of them tell you. You can't. And as far
No.
as the guy in Nevis is concerned, I know what I'd be doing. I'd be going in and saying to him, Dr. Nevis, I take my instructions from Dr. Antonarakis, or I take my instructions from Dr. Schultz. I just like to make sure you're on board, and that's okay.
Right. That's what I need. Someone will listen
Vic,
to me. Right.
Vic,
Yeah.
you have your hand up.
Yeah, I was just going to comment that I think I recently saw some ongoing studies where they were combining Keytruda and PARB. And I think both of them, though, they were using ADT in combination. So it was something like ADT Keytruda, ADT PARB, and then ADT combo, if I'm remembering correctly, was the three arms of the study.
I'll look into that for sure. Okay, that's my news.
Okay, Peter. Joel.
Yes, Dr. John. On 11 February, I fly to Houston from Virginia to see Dr. E. On the 12th, I take my 6th PSMA PET scan. And also the same day, I take a whole body MRI, which both of them I had last August also. And then I see Dr. E in a televisit on the 15th. I also take an FDG PET scan from the VA on the 29th of February. My real comment is that I also call for lodging in Houston, and the Hope Lodge will not take prostate cancer patients anymore, or any cancer patient anymore, unless you have a partner going with you. If you don't have anybody going with you, they won't take you because there's a lot of, I guess, sick cancer patients going in there, and they need extra help, and they don't have the help if they're alone. And the Hope Lodge is not responsible for their health care. So that's one thing. I don't know if that's a Houston thing only for the Hope Lodge, or there are other 29 locations around the country. So that's one thing. Number two is I did call the American Cancer Society to get a reservation for the extended stay America hotel. And they offered me a rate of $73. But because I've been to their facility 2 or 3 times already, they send me almost daily emails with discounts. And I was able to do directly with them for $71 a night. So that's in this situation, American Cancer Society failed to give me a better break than they had before. Before I was paying $50 a night with the American Cancer Society. So as I said before, if you want to stay at an extended stay America hotel, you have to go through the American Cancer Society first, and then they give you a code, and then you can call the hotel and make reservations. So that's the changes in the Hope Lodge and the extended stay America. So that's it for me.
Okay, very useful.
Thank you. That's very helpful. Thank you so much. I mean, people listen to this. I don't know whether our genetic counselors are aware, but you actually could have just listened to a recording or one of the recordings, because these are recorded each week and we get a couple hundred people listening, and it's so useful when we bring out this information. You're doing a lot of good for a bunch of people, General.
One thing I should say, in case somebody didn't know, the Hope Lodge is totally free. So if you can get in the Hope Lodge, you don't pay for anything.
Okay, well, you need to find somebody who you can call your partner and take them down with you. That's what you need to do. Maybe you can recruit a little bit and see who'd like to be your partner.
Take Mike down from Denver to see Dr. E.
That's right. Maybe you and Mike can go down and see Dr. E together, and you can both stay in the Hope Lodge.
Be
Who
each
was it?
other's partners.
You know, Jerry, just lost his last name, but my buddy Jerry, who passed away, he used to go down with his son. He used to take his son down with him, and I think they stayed in they stayed in the Hope Lodge. Jerry Deans. Jerry, oh, you can't see because it's. Can you see?
There he is.
No, not really.
Yep.
Yes, there
Just
you
get
go.
flashes of it. Yeah.
Yeah, Jerry Deans used to go down to and stay in those Hope Lodges with his son. So it doesn't have to be. It just has to be someone to help you out.
Yeah, I do have a partner to go with, but I didn't know at the time when I was trying to make the reservation that I needed that because they just changed the rules a few weeks ago.
Okay. Well, thank you very much for updating us on that, Joe.
Oh, Frida, you're next.
Yeah, an update. I was in remission for 5 years, and about 6 weeks ago, my PSA came in at 0.13, and we decided to wait a little bit and try and see what would happen in a few weeks. And so about 3 weeks later, it went up to 0.17, and so the doctor scheduled a PSMA PET scan, and the insurance rejected it. And so they tried another place, and they rejected it also. So we waited a little bit, and we did another blood test, and my PSA went down. So it was at 0.13, then it went to 0.17, and then just today I got the result of the test, and went down to 0.15. So I really don't know what's going on, but I'll be talking to the doctor in a couple of days, and we'll see if he wants to wait a month or he wants to try and get the PSMA scan anyway. So I don't know. So, anyway, a little bit nervous that it's come back, but the doctors have assured me that they think they can keep it in control because of my 5 years of remission. My Gleason is 4.4, so that could go either way. And that's my update.
Paul, have you submitted that what's his name, the doc, Dan, the radiation oncologist at Boston, at Dana-Farber?
No, I haven't. I don't have
D'Amico.
I don't have a
D'Amico.
radio.
No,
Where?
no. I sent you, you asked me about this, and I sent you the link for an article by Dr. D'Amico that we have spoken about in this group several times, and also we featured it in the reminder.
Yes,
Where
I did.
Dr. D'Amico, did you send that article to the payer?
No, I did not. I read it,
Okay.
and I
You
understood.
need to send that article to the payer. You need to send it to the payer. That's what it says. That's what D'Amico said. He said, if you get pushback, send this to the payer. And that's what I told you in your advice. You guys, if you don't want to follow what we suggest, fine, but don't come in and complain that they're turning you down. You need to send that article to the payer. He was very specific as to why he published that article. And he said, I'm publishing this article because the payers don't get it. And they should be scanning underneath 0.2. So
Okay.
you've got to find that reference and you've got to send it to the payer with your appeal.
Well, okay, I understand, but one of my frustrations is it's very difficult to communicate with, there's the hospital, the facility that gives the test. There's Humana, which is my insurance. There's the doctor and communicating with all these is very difficult. It's not like
Okay,
I
but
can.
that's your job. That's what you got to do. Look,
It's not like
we can
I
only
can.
make you your best advocate. We can only make you your best advocate. When what you've got to do, you can appeal. If you got turned down, you, Paul Frieda, can appeal the Humana decision. And when you appeal that Humana decision, you have to fill out forms. And when you fill out those forms, you include the reference from D'Amico and Peter Carroll. And that carries weight. And that's why we tell you this.
Yeah,
Yes, if you don't do it, you get pushed around.
I'm trying to tell you that I'm not ignoring your advice. I'm dealing with the bureaucracy, and communicating is extremely difficult. I can't send an email to any one of those places and get a reply. And then when I call, getting a hold of someone who can make a decision is also very difficult. So it's
Have you
unbelievably frustrating
appealed?
dealing
Well,
with the
let me
Have you,
intervene here.
hold on one
dealing with
second, John.
the
Hold on
maddening.
one second. For clarification, have you appealed?
No, I don't even know who to
Okay,
talk to.
then you just call up Humana. I have Humana. You call up Humana and you tell Humana, you call up the people and you say, please, can you tell me how to appeal? I've been turned down. I want to appeal. They'll tell you how to appeal. They all have processes. Jim Ward, can we put it in the chat? Not right now, man. I mean, this D'Amico, it's D apostrophe AMICO, and it's definitely in a past reminder, and we can look at it. We'll look for it. But you know, I remember that when I wrote this up in the reminder, I said, guys, bookmark this article. You'll need it.
Yeah.
You know, bookmark it. You'll need it. And this is why. Because we can't wipe your asses all the time. We can do our best to show you what to do, where to go. But it's, you know, sorry, it leaves me a little speechless. But I will try and find the D'Amico article. I think I bookmarked it, and I think I can pull it up.
It was in your email. I can find it. It's in your email.
Yeah, but Jim Ward needs it too. So
Paul,
I'll send the link to Jim.
Your rejection letter from Humana will tell you how to appeal. There's several levels of appeal, and if you keep on appealing up several levels, you'll probably win eventually. But the letter that tells you and your provider that they denied coverage will also have a few sentences in there for how to make your first level appeal. In addition, if you're lucky, the people doing the scan will have somebody that specializes in helping guide you through the insurance company appeal maze. And so it might be worth giving a call to the provider of the scan also, just in case they have a special person designed specifically to fight battles with insurance companies, and they'll hold your hand through the whole appeal. So those are the two contacts that I would recommend.
Great suggestion, John.
And the nice thing is that because your PSA dropped a little bit, you don't have to feel like you're under time pressure.
Yeah, right. The PSA is, not that high. Yeah. All right. Well, so I'm going to see what the doctor has to say tomorrow, and we'll try to reapply and appeal if they turn us down.
Okay, and Rick has just reposted that D'Amico article, so
there's the D'Amico, and there's the top one is the Medscape article. The bottom one is the actual article in JCO. And again, don't rely on the docs. It's time consuming. They don't put in the time. Certain docs will. We know who they are, but they don't all put in the time. So you have to drive the bus.
Now I have a couple of minutes left. There were 6 people that came in after I went around the room, and I wondered if any of you last 6 people had anything you needed to bring up, because we could probably just squeeze one more guy in.
I came in
Stan
to
or
Rick
Nigel. What's that?
I came in to give Rick an update. He gave me the suggestions from last week.
Okay, you want to do that now?
Sure. Bill Lee. Quick background: June of 2023, PSA was at 0.99. December it went to 2.02. And then the doctor I had, or still have, but wanted to wait until June, which is like 6 months from then. So, anyways, Rick said, get with Elisabeth Heath, which I called, got an appointment for February 12th.
Great.
Great.
And then
Great.
then today my radiation oncologist called me to check on me to see how things were going, and told him, I'd gotten a second appointment with her, and he says, "Oh, great! I've worked with her. I know her. I send patients to her. She sends patients to me." Gave me some backgrounds on a couple of patients that were really bad off, and now are basically cured. So he was very happy, and he's getting me signed up for a PSMA PET scan before I meet with her, hopefully.
Perfect. You'll love her. I'm sure you'll love her. I really hope I run into her in San Francisco this week. I mean, she's going to be pretty easy to spot because she's little and she's easy to see. And if I do, I will definitely stop her and introduce so that she knows us at AnCan. But we've sent a bunch of people to us, and I'm really pleased, Bill. That's a great move on your part.
Yep. My radiation oncologist really gave her kudos also. Said she was really good.
She's lovely. Yeah. Yeah. I mean, it's not just she's a good doc. She cares.
Right.
She's compassionate.
That's it.
John?
Student. Yeah.
Yeah. Can we hear from Kate and Sophia? See what get their reflection on how our meetings are, because we're a pretty unusual group.
That'd be fine. And also, you guys, I put Rick's and my email up on the chat in case you need any follow-up or anything. Although, as Rick said, you're welcome to explore the AnCan website. There's all kinds of stuff there. Any reactions to group?
This was really interesting. Thank you for letting us sit in. You guys know so much, probably more than we know right now, because we just started our cancer genetics class. So we're just a couple of weeks in. We're first years. We just started our spring semester a couple of weeks ago. But this is a great resource you guys have here. It's really interesting to hear all the connections that you have, and it's great that you guys have this to support each other.
Yeah, I was thinking the same thing. Thank you again for letting us listen in. I was thinking as we were talking how when we become full genetic counselors one day, knowing resources like this exist and being able to refer them to our patients who might be struggling is really beneficial, and just kind of any resources we can get to help others get connected is really beneficial. So we're really grateful to know about this.
Great.
So I am going to suggest to you to go to our website, look at our advisory board, and you will find on that advisory board a genetic counselor called Lindsay Byrne, Byrne. She's lovely. She's great. She's actually counseled Frank Fabish. Put your hand up, Frank. Wave at them. And we've nominated her for Genetic Counselor of the Year, and she got into the final group. She wasn't. And you should use her as a resource and tell her AnCan sent you. And I think you'll find her very, very, very helpful. And she specializes in prostate cancer. So she's at the James at the Ohio State, the James Comprehensive Cancer Center at the Ohio State. And if you got questions, she would be a really good person. And I'm volunteering her. I will probably see her in San Francisco because she's got a poster, and I'll tell her. And I bet she'll say, "Oh, that's fine, of course," because that's the sort of person she is.
What school are you guys from, in case Rick remembers when if he sees her?
We're at University of South Carolina.
Okay, USC.
Great.
Okay,
That's great. We'll definitely reach out to her.
Yeah, she's lovely.
Yes, thank you.
Pleasure.
Well, guys, you've wasted another 2 hours on AnCan of your precious life. I'm glad to see you all. There will be there'll be no group next week, and we'll see you the week after. Somebody has a comment? I couldn't see who it was.
Yes, John, you said you guys. This is a rare opportunity to say you guys and you gals.
Yeah, that's right. In this group, we don't get to.
Right. And don't forget, if there's any vets in here, and I know there's a couple, we have our veterans group with Captain Jim Marshall on Thursday. And if you have any friends who are vets, send them. That group is not disease specific. It's about healthcare. And I'm hoping Dr. John's going to be able to sit in on that one because I won't be around. So if you've got any friends who are vets, send them to that group. Captain Jim does some remarkable stuff. God bless him. And, if you're a vet and you're having issues, we know between Dr. John and Sylvester and Captain Jim, we got that VA system down.
Good night, all.
Good night.
Good night.
Good night, everybody.
Good job, John.
Great job.
Have a good trip, Rick.
I'll get to my stuff next week.
Oh, who was that?
Tom Matika.
Okay.
Yes.
Okay.
Tom, if you want to hold on, we can talk to you right now. Do you want to hold on?
Sure.
Go ahead. We've got 10 minutes. Sorry. What's up?
Oh, okay. Yeah, I was gonna put it off till next time. Well, I just I'm just using the Firmagon right now, and my PSA is down to 0.01. And I'm just kind of I feel like I'm kind of cruising and I'm okay and fine. But I went and I saw another I think a GU oncologist over at OHSU, and she, along with my reading of the guidelines, had got me thinking about doing another a second hormone reducing medicine in my treatment. Because it says that you get a little bit better outcome. So I started looking around and kind of focused on the enzalutamide, and my doctor had put in an order for that. But I started looking at the cost of this and my insurance situation, and to me the cost was extreme. And I'm exploring through my oncologist in Vancouver, Washington here, my other oncologist, how I might pay for that. But my question, so that's the background. And so my question is, I know I can go on and just continue to use the Firmagon, but I want to add something to that. So could I add some, cost is an issue. Could I just add something like bicalutamide and satisfy that?
No.
Okay.
Don't. One of the things I've noticed, Tom, is you want to regulate your own treatment. But the thing is that all of these guidelines and what Dr. Sokolova recommended to you are based on clinical trials.
Yes.
And these clinical trials are worthwhile. Yes, you could do whatever you want, But if
Yes,
you want to
sure.
stay this side of the grass, you got to follow the clinical trials. And the clinical trials say you need to add a second-line antiandrogen. Now,
Yeah.
what are they? We don't love enzalutamide. Darolutamide is a better drug. Some of these drugs are available to you generic, like abiraterone. So you can get it cheaper, and you can get it also through what's his name, Mark. Who's the guy that's got the cheap pharmacy, Dr. John? Mark Cuban. Mark Cuban, who has whatever that cost plus pharmacy or whatever it's called. There are ways to get it, and Dr. Sokolova can help you. If you want to get it, don't go back. Don't go to your local person, because your local person doesn't know what they're doing, because otherwise they would have given you what they should have done in the first place, which was the second line antiandrogen along with the first line antiandrogen.
And
So don't.
abiraterone, if it's
You know,
available cheaply, is a very potent drug. You don't have to feel like you're compromising at all.
which one is
You
that?
know,
Abiraterone.
abiraterone. But, go back to Dr. Sokolova and say, look, there are financial issues. Can OHSU help me? There are all kinds of programs. There are all of these companies have patient subsidies based on income. So you can, if you don't have the income, you can get that. You can apply for that. At this time of year, there's a whole bunch of different places, programs that have money, like the Patient Assistance Network and the Patient Advocacy Network, and there's all kinds of places. You do your research. One way of doing this, by the way, is to go to Zero and call 0360 and tell them you need financial assistance, and they have a program to help you. And they are supposed to walk you through it. We don't have staff to do that, but Zero has $10 million a year, and that's a program that they have. So go to Zero, what's it called? Zero Cancer, I think, or I think it's zeroprostatecancer.org, and you'll see 0360 right there on the top, and call up 0360 and say, please, can you tell me about getting financial subsidies for the second line antiandrogens?
Okay,
So
well,
I,
you know,
you've got a lot of
I
options.
personally, Tom, I personally got a whole year of free darolutamide from the manufacturer by calling them up.
darolutamide?
Yeah, that was like $15,000 a month or something.
Yes, right. Yeah, that's the same thing with that with the enzalutamide. And they are
Yeah.
working on this oncologist on this side of the river. Uh, they are working on getting these costs reduced to nothing almost by having the manufacturer contribute. And I heard you about the darolutamide, but we were just talking about the enzalutamide, and they
Hmm.
are working on this. They do put out some effort at the oncologist to try to get this
Okay.
reduced.
Okay. I mean, if you feel comfortable, but I know that people like OHSU, they are an NCCN hospital, and they have staff and they have extra people to do that. But if you're happy with your local people, go with your local people. But if it were us, we would say go with abiraterone and plus prednisone or darolutamide. The enzalutamide can
Right.
be a bit tough. And the
Okay.
apalutamide and enzalutamide are pretty much the same. The darolutamide will have less side effects.
Okay. Now I just want you to know that these two doctors, the ones that I've contacted, I was told by Dr. Sokolova. I don't know if this means anything to you, but I do want to get your reaction. She said that she and Dr. Cosgrove share patients. Now, I don't know what that means or if that means anything to you. What do you think?
Well, I don't know who Dr. Cosgrove is, but what I
Right.
do know is Dr. Cosgrove isn't, he is not following the guidelines. So that's why they probably share patients. So when he gets out of his depth, when it comes to prostate cancer, he probably sends patients over to Dr. Sokolova. But that's why we directed you to Dr. Sokolova. She's absolutely right. She knows the guidelines. That's why she said to you, you should add a second line, another drug.
Right. Now let me explain this, because I hear what you're saying, but initially Dr. Cosgrove, I'm not defending Dr. Cosgrove. I'm trying to understand what you're trying to tell me here. Dr. Cosgrove initially suggested that I use Lupron and bicalutamide. Those two. That was his initial.
Okay, but we've talked, Tom. We've talked to you about this. We have. Bicalutamide is used before you start Lupron. That is the purpose of the bicalutamide.
Temporarily.
So bicalutamide and Lupron are used together. Occasionally, some doctors many years ago used to use them both at the same time, but that was never a protocol. But some doctors like to do it. Dr. Cosgrove should, according to the standards, the guidelines, should have prescribed Lupron plus a second-line antiandrogen. That's what Dr. Sokolova is telling you, and that's what we told you.
Like what? So, what would be that second-line antiandrogen?
Enzalutamide, darolutamide, apalutamide, or abiraterone.
Okay, that's clear. Thank you.
Yeah. Okay. Now, This is what we're repeating this several times, and this is what Dr. Sokolova is telling you. Dr. Cosgrove is a general medical oncologist. He is not up with the times. And the reason he probably uses Dr. Sokolova, as I just said, is because he needs help when it comes to prostate cancer. So you may feel great. You may do well. You can stay on just the Lupron if you want, or whatever you're taking. But we know now that to remain on the right side of the grass for the longest period of time, you should be on a second drug with that Lupron and not bicalutamide. But bicalutamide is what's called a first-line antiandrogen.
So we have to
taking
clear the room.
Firmagon.
We have to clear Firmagon's fine instead of Lupron. We have to clear the room for the next group. I just want to make sure Larry's not here waiting to ask a question. Larry, are you still there?
No.
Oh, he's in Neverland or something. Okay. Okay, Tom?
Yes, sir. Thank you very much, guys. I appreciate it.
Okay. Goodbye.
Have a good trip tomorrow, Rick.
Good night now. Yeah, thank you very much.
Good night. John, hold on a second.
Okay.
Bye-bye, Tom.
He was calling me, Tom.
So long now.
Okay, bye.
Oy, sorry, my patience was getting a little thin tonight. I mean, you're better at this with some of these people than I am. But with Jim Ward asking me, can I have it right in the middle of everything? I mean, he knows. Oh,
what? Somebody coming in?
No, I want to stop the recording.
Oh yeah.